Hi, my name is Dr. Fred Lado. I'm the director of the Epilepsy Division at Northwell Health Central and Eastern Regions, and my charge today is to speak to you about neurostimulation for epilepsy. I'm going to use this red pointer to highlight items on the slides, and let's go ahead and begin. So this is an outline of the talk. We're going to first just define what we mean by neurostimulation. I'd like to address when we should consider it in the treatment of epilepsy. There are different types of neurostimulation, including VNS, RNS, and DBS. And how do we compare and choose among these different types of stimulation when we're considering which one might be best? And then what do you reasonably expect will happen during and between doctor visits when you have a neurostimulation device? So first off, what is neurostimulation? And to begin with, neurostimulation is not restricted to the brain, as I'm showing in this illustration. It can actually be applied to the spinal cord or to the nerves, and it's actually found a wide range of uses, which we'll just briefly touch on. It's been used for Parkinson's disease. That's perhaps one of the best known applications. Here we have a picture of Michael J. Fox. He is perhaps the best known patient that's received deep brain stimulation for treatment of tremor in Parkinson's disease. But it's also used for chronic pain in the form of spinal cord stimulation. Gastroparesis, that means when the stomach doesn't empty well, it can be stimulated to empty better by a pacemaker device, a neurostimulation device. Gastroparesis, that's the same thing. Bowel control can be used to strengthen the control of the bowel. Bladder control, similar idea. And of course, the topic that really interests us here is seizure control. So for seizure control, what are we really talking about? Well, neurostimulation will consist of a treatment of small electrical pulses delivered through electrodes to either a nerve or to a structure in the brain. So we've got the vagal nerve stimulation, where there's a battery pack, pacemaker pack, implanted right below the clavicle and stimulates a nerve in the neck. We have responsive neurostimulation. In this case, the electrodes are on the brain or within the brain, and we'll talk more about that. The stimulator pack is actually nestled in a cavity the surgeon creates in the bone. And then we have deep brain stimulation, where the electrodes are in a particular brain region called the thalamus, and the stimulator pack is in the chest. So each of these has advantages and disadvantages. They differ in where the electrodes are placed. They differ in whether the stimulation is continuous, round the clock, or whether it's triggered in response to detection of a seizure. And they each have different levels of effectiveness and different side effects. So it's also important to say what stimulation is not. It's not high voltages applied to the brain. It's not shocks to the brain. In fact, people with neurostimulation devices often don't know it's firing at all. And so I've created just a comparison here. We have a 60-watt bulb that will deposit 6,000 milliwatts per second of energy in the brain. A 9-volt battery will deposit as much as 1/3 of that amount, 1,800 milliwatts per second. And by comparison, a responsive neurostimulation device, and the DBS and VNS devices are similar, will deposit only 3 milliwatts per second. So a lot less power. But the real strength or power of these devices is that they apply that energy to very focal regions of the brain to control seizures. So when should you consider neurostimulation? Well, the main instances where we think of neurostimulation, there are two. One is obviously when seizures aren't controlled. And after appropriate medications, if you've tried 2 or 3 medications and seizures are not controlled, your doctor should be talking to you about surgical options. And those options include finding the seizure location in the brain, and if it's safe to operate, consider resective surgery. But on the other hand, if that region is what we call eloquent cortex, where we don't want to create a disability through a surgery, then neurostimulation is a non-lesional alternative where we can try to control seizures and at the same time improve quality of life beyond what medications alone can do. And so when curative resective surgery is not an option, maybe we don't know where the focus is, or as I said, maybe the focus is in regions that we don't really think should be operated on, then neurostimulation is your best choice. And in this diagram here, we're showing a couple of the regions where we would not consider surgery. In this case, this is a language area called Broca's area in the frontal lobe, and we have another area called Wernicke's area in the posterior temporal lobe, where if that's where the seizures come from, the cost of doing surgery there is simply too high, so we would think of neurostimulation as a treatment approach. The other reason to think of neurostimulation is that it reduces risk of sudden unexpected death in epilepsy. And this is a difficult topic, an uncomfortable topic to talk about. Fortunately, death from seizures is exceedingly rare, and yet we have to recognize that it can happen, and sometimes it does happen. In the population of individuals with seizures, that rate is about 1 per 1,000 per year. However, if you look at the population of people referred to epilepsy surgery, these are the people who have the worst seizure control, almost by definition. That rate can be almost 10 per 1,000. Here, 9.3 people per 1,000 per year. It's a very high rate. For patients referred to the epilepsy monitoring unit, when we look at that population, again, a group where seizures tend to be poorly controlled, that rate can be 7.5 per 1,000. So these are elevated risks of SUDEP. In multiple studies, we've seen that for DBS, VNS, and RNS, the rate of SUDEP is cut by anywhere from 1/3 to 1/4 of the baseline rate in these patients at high risk. People with epilepsy overall, without these high risks, that rate is about 1 or just under 1 per 1,000. So let's dive in and talk about the specific types of neurostimulation. The first one we'll touch on is vagal nerve or vagus nerve stimulation. The stimulator, as I mentioned, sits under the clavicle. The electrode is passed into the neck, where it stimulates the vagus nerve as it emerges from the brain. So what is the vagus nerve? Well, the brain is divided into the hemispheres, and here we have the brainstem, and out of the brainstem there are multiple nerves that emerge. Each of these has different functions. Some are for sensation in the face, some control eye movements, some pass the hearing into the brain. And the vagus nerve is actually in charge of controlling a lot of the viscera, the guts, the heart in the body. And the name comes from Latin, vagus, meaning wandering. The nerve wanders through the body, carrying out its work. Here we have an image of the left vagus nerve, and you can see it travels down in the neck. There's a branch that comes back up to the voice box, and other branches that head on down, pass by the heart, and then you can't see it all the way here, but into the stomach and into the proximal part of the intestines. There's a right vagus nerve as well. There are fewer laryngeal, that is voice box, projections, although it also passes by the heart. Most of the vagal nerve stimulation implants that I'm aware of go for the right vagus nerve because some of the side effects are better because of the sparing the voice box and a little less cardiac effect. So, how effective is vagus nerve stimulation? Well, this just illustrates the device. Here's the stimulator pack. This is a control wand the doctor will use to program the device, and this is the tablet a doctor will use to enter parameters for the vagus nerve device. When we look at the clinical trial, individuals who were put into this trial, we compared high stimulation against low stimulation. The comparison group was low stimulation rather than no stimulation because the vagus nerve stimulation can be perceived. The individual with it can feel a little tickling in the throat when the stimulator goes off. And so to control for the placebo effect of individuals being aware that the stimulation is on, they opted to use a low stimulation comparison group. Looking at these two, efficacy against seizures, we see that over the course of 2 trials, we have dark blue and aqua blue represent 2 separate clinical trials, we had a similar effect, almost a 1/3, call it 30% reduction in the number of seizures that people had over the weeks of this trial. This was a 12-week trial, and over that period of time, we saw an overall reduction of about 30%. If we define the benefit in a slightly different way, sometimes clinical trials look at what's called responder rate. That is, the number of people who have a 50% or more reduction in their seizures. These 2 trials showed anywhere from a 25 to almost 40% responder rate in the high stimulation group and relatively less in the control group. The other thing that this initial trial couldn't address, but subsequent studies did, is that with time there is improvement ahead for vagus nerve stimulation. Looking at this data, which was a retrospective of multiple center experiences, we can see that initial responses in the range of 20 to 25% responder rate, that is, people with a 50% or more reduction, improved to almost 55% responder rates by a period of 4 years after implant. And so these devices, we'll see as a recurring theme, neurostimulation devices, the benefits tend to improve as time goes on. What are the other benefits of vagal nerve stimulation? Well, one of the big ones that we found subsequent to the introduction of the device is that it appears to improve depression. And in fact, in some cases, it's actually placed for depression. Since depression and mood problems are often a comorbidity or a illness that occurs with poorly controlled seizures, this is one of these side benefits that the vagus nerve stimulation offers. This is clinical trial data. There was a population of patients who received a vagus nerve stimulation for depression. The green is treatment as usual. So in the control group, depression does improve over time. This is the response rate among patients with treatment-resistant depression. There is an improvement, but in the population that received the vagus nerve stimulator, that improvement was more than twice as great, meaning more than twice as many patients improved in the same time period compared to the ones who did not have vagus nerve stimulation. If you look at relapse rates, so after the individual improves, how likely are they to develop a new depression? In green here, we see the relapse rate that half of people relapse within 18 to 20 months. Well, with vagus nerve stimulation, that number of relapsing was only about 30% instead of 50%. And that pattern continued going out, that the relapse rate, even at 4 years, was only about 50% compared to more than 70% relapsed with treatment as usual compared to the vagus nerve stimulation. Other measures of the vagus nerve stimulator include quality of life, impact, and here we have some data on that. The blue is vagus nerve stimulation plus best medical practice. That's the BMP here. I apologize that the text is so small. Compared to red, which is the best medical practice only without the vagus nerve stimulation. And these are an instrument called the QOLI 89. This is a quality of life survey. So individuals with the vagus nerve stimulator or in the control group completed these surveys with their physicians. And what we saw was that at month 0, that's the baseline, month 3, the vagus nerve stimulation population are reporting an improvement, And by month 12, that improvement has increased. Compared to the best medical practice only, the improvements were modest and did not increase over the course of the trial. This trial also looked at the change in baseline seizure frequency. The best medical practice here, the treatment seizure rate, baseline seizure rate, did not really change throughout the trial, whereas there was an almost, call it 22-23% reduction in seizure frequency in the treated group. And finally, the most recent generation of vagus nerve stimulation devices has incorporated heart rate detection. This grew out of the experience that with many seizures, both convulsive and non-convulsive seizures, one of the earliest changes is an acceleration of heart rate. So tachycardia is a biomarker of seizure onset. And so when the vagus nerve device, because it sits in the chest, can measure the cardiac rhythm, and when it detects that the heart rate increases, it can deliver stimulation on that trigger. Compared to a population, this is two cohorts. One is a group of patients implanted from the beginning with the heart rate detecting vagal nerve stimulation device. This is the post-Aspire SR. And then the other is individuals who already had a vagus nerve stimulator but needed a change, a battery change, because the batteries wear out after a few years, and went from an old device to the new device. And looking at that population first, in the old stimulator device, if we look at the group of people who had, let's call it better than half, 50% or better reduction in their seizures. That's going to be the light blue, the aqua green, and the olive green categories. So in the group of patients with the old device, we see that 32 plus 16 is 48, plus 5 is 53% improved, compared to here where we've got, let's do the math, 64% improved. So we have a substantial improvement when we added heart rate detection. Now when we take all comers and we put the device in, we see some improvement compared to the cohort with the old device, but not as much as the cohort that had the replacement. And this probably represents that time benefit, that having the device for a longer period of time helps get more efficacy out of it. So this group was seeing both the benefit of the heart rate detection as well as the benefit of having had the device for a longer period of time. So that's all of the benefits from the vagus nerve stimulator. What about the adverse effects? What kind of problems do people run into? So for the most part, in the clinical trials that have looked at this, and this here I'm showing you the experience of over 500 patients. Hoarseness, because of that recurrent loop of the vagus nerve that goes to the voice box, when the stimulator's on, it can cause some transient hoarseness. And that can happen in anywhere from a third to almost 2/3 of people, depending on which of these trials we look at. Less common, but in some cases more bothersome, is cough. About anywhere from 1 out of 8 to 1 out of 5, maybe as little as 1 out of 10 or 15. We see cough as a problem. Tingling in the neck and throat is sometimes a problem. In my experience, this hasn't been a significant limitation. Pain, I have to say, is much rarer and probably related to the intensity of stimulation. So if the stimulation's too high, it can be uncomfortable, but that's the role of the doctor and the patient to adjust that stimulation to something that is comfortable. So as a practical matter, this is not a problem that I see very often. Dyspnea is an interesting problem. Dyspnea is the medical word for shortness of breath. And this is going to become important in a moment when I'm telling you about sleep apnea. Headache, similarly, has not been a significant problem in my practice. I think this is probably something where adjustment of the intensity of the stimulation makes a big difference. And then, of course, any device implanted brings a small risk of infection, so that was part of the adverse risk profile. So let me pause and touch on sleep apnea, because this was something that came out more recently. This is a report from 2011, and it looked at individuals with vagus nerve stimulation devices implanted who also had sleep studies because there was some concern about sleep apnea or some sleep disturbance. And this is a graph of the data of the recordings from a sleep study. So here we've got a compressed time scale. So these are EKG tracing. Here you see many heartbeats. This is airflow. Actually, an airflow sensor at the nose or mouth measures the amount of air passing, and you can see the breaths, a number of breaths per minute. This is a chest belt that measures how much expansion there is in the chest or equally in the abdomen. And then we've got a measure of heart rate and oxygenation levels. And I draw your attention to this period here. When the VNS is on, that's this top trace, and you can see the amplitude or the width of this line increases, of the green line increases when the VNS is on. The respirations change. Instead of the slower and larger movements of air that you see when the VNS is off, when it's on you see smaller amplitude, lower volumes of air being moved at a higher frequency. So you're breathing faster but less overall. And we see that mirrored. The chest movements are faster but less extensive. And that seems to be replicated each time the VNS comes on. Here we have this area marked desaturation. That's when the oxygen saturation falls below a given threshold. Usually about 92% is determined to be a desaturation event. And so these investigators found that the VNS can cause or exacerbate sleep apnea in patients with a pre-existing diagnosis, meaning if you're susceptible to sleep apnea, VNS may make that problem worse, which is something for everyone, the doctor and the individual, to consider in weighing the risks and benefits of this device. So let's turn to talk about responsive neurostimulation. And just a reminder, responsive neurostimulation, in contrast to vagus nerve stimulation, is directed at the brain regions causing seizures. So while vagus nerve stimulation is implanted in the chest with an electrode going into the neck, responsive neurostimulation, the stimulator is implanted in a well created by the surgeon in the bone of the skull, with electrodes directly over the regions of the brain causing the seizures. And as a reminder, we use this device when we know fairly well where the seizures are coming from, but because they're eloquent regions, because they're regions that we can't risk surgery on, we choose instead to stimulate them to control the seizures non-lesionally without creating an injury in the brain. Sometimes we'll also use RNS when we have more than one region causing seizures, because in general we're willing to do surgery on one spot, but if we start to do surgery on more than one spot, the risks of side effects goes up significantly. So we prefer never to do surgery in two spots or more, and instead turn to something like responsive neurostimulation, where we have multiple electrodes, each of which can be used to treat one of the two spots. The other advantage of this is sometimes we have two spots that might cause seizures when we do the initial evaluation, but what we really don't know is when the person's at home taking their medicines on their regular schedule, are both spots equally responsible for the seizures they're having. It does happen, not infrequently, that we put the RNS device in, and what we find is over the course of a year that one of the two spots is responsible for 90% or 99% of the seizures, and the other spot is relatively quiet. And then that becomes an individual who has the option of doing more definitive resective surgery on the more troublesome spot and sparing the spot that's not causing as many seizures. So these are all potential options that the RNS opens up. So how does it work? Well, this is an example of some of the data that the RNS device will record. It is recording and digitizing brain activity continuously during the entire time that it's in place. And these black traces here, you see 4 of them because there are 4 recording channels. 4 of these traces correspond to the electrodes, the 2 different electrodes that are present in the brain. And you can see here that one of the traces starts to show more activity. You can see how it gets wider here. That corresponds to the beginning of a seizure. And this device, the RNS device, will detect that change in the signal and will apply a little burst of electrical stimulation to that electrode. And then it'll stop. That's a relatively brief burst of about 100 milliseconds. And then it'll start recording again. And in this case, you can see that the seizure discharge continued. And so the device detects that and it delivers a second stimulation. And in this case, you can see that the seizure discharge has now changed. It's gone into a termination pattern and the seizure's over. So the device has aborted the seizure. That's the idea behind the operation of this device. It's constantly sampling the brain activity. When it detects a seizure, it delivers a pulse of currents to terminate the seizure at its origin. Because the detection of the seizures requires tuning, customizing the device to each individual's pattern of seizures, it requires uploading some of this data to a server so that it can be analyzed by the doctor to adjust the parameters. And so individuals with an RNS device will have a computer at home and a wand that allows them to upload data from the device through an internet connection to a secure server that then makes the data available for analysis so that the stimulation parameters can be adjusted. And this is something that individuals really need to develop a habit of doing, not necessarily every day, but every few days, once a week at least, because the device is finite. Essentially, it's constantly recording, and it has limited memory, it has limited power. And so if the data is not uploaded regularly, old data gets overwritten with more recent new data. And so regular uploads allows the doctors to have the best idea of what's happening in order to adjust the stimulation parameters. So the clinical trial that looked at responsive neurostimulation was set up like this. Prior to surgery, there was a baseline period just to assess how many seizures were occurring. Post-operatively, there was an implant, and then for 1 month, nothing was done. The stimulator was not turned on. Then the stimulator was turned on, and there was a period of blinded evaluation. That is, half the group were turned on and half the people were not. During that period of blinded stimulation, nobody could tell if the stimulator was on because the brain, although it's full of neurons, it actually has no nerve endings to detect stimulation. So the brain doesn't sense the stimulation that's happening. And then at the end of that blinded evaluation period, there was everybody's stimulator was turned on, and they were all given treatment. So here's what happened. Overall, in the blinded period, the treatment group saw a 37, almost 38% reduction in their seizure frequency. And if you look at the last month of that, it was as high as 41%. In the control group, there was initially 17% overall reduction in seizure frequency, and in the last month, that number was 9.4%. This property of the control group showing a benefit and then gradually going back to baseline is a phenomenon that's often observed in clinical trials called regressing to the mean. And what that means is the people entering clinical trials are the ones who actually are most affected. They're going through a particularly bad period in their seizure control, and that's probably one of the reasons they're in this clinical trial. And then over time, we catch them on the clinical trial at the negative, at the worst end of the fluctuation, but then over the time they go up and down, and they kind of go back to the middle. So this process of regressing to the mean often shows as if there's a benefit in the control group, when in fact it may just be that we're catching them at the bottom of a otherwise normal fluctuation that would have happened with or without the treatment. Of course, there may be a benefit to simply implanting the device. There's been some discussion about that. But in general, I think these control responses represent this phenomena called regressing to the mean, not a true treatment response. What happens when we look over time? Well, here's the same data shown in a different way. We have the initial implant. In the first month, it's not turned on. Then it is turned on, and we see that the control group and the treatment group have about the same. In that first month, there's optimization of the stimulation parameters. They're tuned to each patient. And then they enter the blinded evaluation period, where one group, the stimulator's turned off, the control group, and the other group, the stimulator's left on. And over that 3-month period, you see that the benefit continues to improve for the stimulation group, whereas where the stimulator was turned off, they are regressing back to the mean. At the end of that blinded evaluation period, the control group is now back to its baseline, and the stimulation group has had progressive improvement. Here, the total seizure count had dropped on average from 40 to about 22 per month in the treatment group. And then the stimulation is turned on for everybody in so-called open label period, and we see that the benefit continues in the treatment group, and it resumes. The benefit now begins to kick in for the control group because their stimulator has been turned on as well. So how else can we parse this data? Well, we can look at responder rates. That is the proportion of people with more than 50% reduction of their seizures. And we can also look at the median or average reduction in the number of seizures, the percentage reduction. And we see these are similar. The responder rate and the reduction of the average or median reduction of seizures goes up over time. If we look at 6 to 8 months compared to just over 2 years, we see that the rates go from the mid-30s up to almost 50% over the initial 2 years. And this particular report looked at the real-world experience and said median percent seizure reduction is sustained at 60% or greater over additional years of follow-up. So a substantial improvement over the initial few years. This is a multi-center study from data taken from 8 epilepsy centers with a total of 149 patients that just shows us something similar. In this case, they're asking the question, are there particular types of epilepsy that respond best to RNS? And this MTL is mesial temporal lobe. Neocortex is essentially all other epilepsy that isn't MTL. And what we see is that all of these improve with neurostimulation. They all improve over time. And maybe there is a slight benefit for neocortical epilepsy over MTL, but as you can see, they're really quite similar. We also, as part of this multi-center study, there was a survey of treating physicians that asked them to assess the benefit each patient had from RNS. And you can see here that there were multiple categories going from very much improved, minimally improved, no change, minimally worse, or much worse, that over 70, maybe 75% had a much improved or very much improved categorization by their treating physician. And in this study, 18% of patients were actually seizure-free at their last follow-up. So this was encouraging data. So what about adverse effects? Well, this comes from the initial pivotal trial for RNS. We had 191 individuals implanted. They were randomized, as I mentioned, to treatment on or treatment off. Treatment group was 97, treatment off or sham was 94. In that moment, there was actually one death from SUDEP at the time of randomization. In the blinded evaluation phase, we had a total of 189. There has been one prior withdrawal due to subject preference, so 189 entered the blinded phase. 2 of them had complications of infection and were explanted, leaving 187 that completed the blinded phase. And then of those, there were 2 additional explants because of infection and 5 withdrawals because of other treatment options unrelated to the study. And interestingly and concerning, 5 deaths. And these deaths, one was suicide, one was a medical illness unrelated to stimulation, and 3 were SUDEP. And this just heightens the point I was making earlier that SUDEP is highest, the SUDEP rate is highest among individuals who have the least controlled seizures. And those are the individuals who are entering trials for neurostimulation devices or epilepsy surgery trials because medicines have not worked to totally control seizures. So this is a group with high risks of SUDEP. If you'll recall, it was a rate almost 10 per 1,000 per year. So if we have a trial of almost 200 people, then we might have an expected rate of 3 or 4 people per year, even in a group this size, who would be at risk for SUDEP. And so these numbers bear that out. We're seeing a SUDEP rate more or less similar to what we expect in this cohort. And as I mentioned earlier, one of the benefits of RNS, along with the other forms of neurostimulation, is the reduction in the SUDEP rate by as much as 3/4 or 2/3, depending on the study. And other side effects that bear mentioning, there can be need to revise the leads that are placed. Sometimes leads break. There have been some reports of increased seizure frequencies. These are generally respond to changes in the stimulation intensity. And then some other adverse effects. There was some instances where neurostimulation interfered with EEG monitoring. The deaths we spoke about here. There were some patients who just had medication toxicity unrelated to stimulation. All right, so turning to the last modality, deep brain stimulation. Here we have electrodes placed in the brain at a specific target location that modulates seizures. The stimulator pack is in the chest. And let's look at the clinical trial data for this. Similar to the prior, we have a baseline seizure rate. Individuals get implanted, and in this case, the stimulator is turned on immediately. And we see that the control group and the stimulated group both see about a 21 to 22% reduction in their seizure frequency at the time the stimulator is inserted. In the control group, the ones that are not receiving stimulation, that seizure rate reduction, as we see, begins to revert to the baseline. But in the stimulation group, we see a continued growing benefit with, by the end of the blinded phase, which is month 3 to 4, third month of the blinded phase, we see approximately 40% reduction in seizure frequency. And just like the other neurostimulation trials, we see that benefit improves with time. So this is looking at long-term follow-up of this surgical cohort, stimulation cohort, over 7 years, the mean total seizure frequency change, median total seizure frequency change from baseline, using two different measures, it improves from year 1 in the range of 41 to 44% to year 7, anywhere from 70 to 75% reduction. So that's encouraging, and again supports the idea that these devices are modifying the seizure circuit over time. Now, of course, 7 years is a long time too, so it's important to realize that this effect washes in only gradually. Now, sometimes people will say, well, how do you know it was the stimulation device? Because 7 years is a long time, and maybe they were changing medications and doing other things, and the stimulator is getting the credit for something that perhaps a new medication did. So the investigators looked at that. They divided the population into the red group here, where medications were added over the stimulation period, and in the blue group, where medications were not changed over the 7-year period. And first off, it makes sense that the responses were a little worse in the red group where medications were added. That's probably why they got additional medications, because their response wasn't as good as what they wanted. In the blue group, where the response was better, they did not get medications added. And what we see is over the first 5 years, they went from an initial 57% reduction in seizures to a 92% reduction in seizures that was also present in year 7. There was a little bit of noise or fluctuation in year 6. That's probably not significant. We see that overall the benefit continued to improve in both groups. And when we looked at types of epilepsy that improved, the DBS is placed in the region of the brain called the thalamus, and that region is highly interconnected, especially to the temporal lobe, but as it turns out, also to the frontal lobe. And somewhat unexpectedly, the overall benefit to temporal lobe seizures in year 1, year 2, and year 3, this was expected, continued to improve, but perhaps somewhat unexpected was that the frontal lobe seizures in year 1, 2, and 3 actually improved even more compared to the temporal lobe seizures. And then in the rest of the brain, there was still substantial benefit, but perhaps not as good as temporal lobe and frontal lobe seizure foci. The investigators looked at whether prior experience with neurostimulation, in this case vagus nerve stimulation, affected the chance of improvement. And what they found is it didn't matter. Whether you had VNS before or whether you didn't, the benefits were the same. And similarly, having surgery, epilepsy surgery, did not mean you wouldn't get a benefit to neurostimulation. So it seemed that the DBS neurostimulation helped all the individuals who underwent the procedure, at least on average, regardless of the prior treatments they had received. With regard to the adverse effects, a little bit different from before. One of the ones, because this thalamic region is so highly interconnected to both the temporal lobe and the frontal lobe, there was an increased report, in this case 14.8%, of depression. Most of these symptoms appeared to be transient and more prominent at the beginning of the stimulation period. Some individuals complained of memory impairment and confusional states. Those two tended to be worse at the beginning of the stimulation period. And then, of course, some other states, anxiety, tingling or paresthesias, influenza. I actually don't know why that's considered or maybe they had flu-like feelings. And then some less common, some report of increased seizures affecting anywhere from 5 to 10%. And these can be improved by adjusting the stimulation intensity. Okay, So that's a view of all the different types of neurostimulation. How do we choose? How do we compare them? How do we decide which one is the best one? This is just a summary slide. And in this case, I borrowed this from Dr. Robert Fisher, who's been a very prominent investigator in neurostimulation in general and in DBS in particular. And he looked at this overall between all the different modalities. What is the median seizure reduction? In the blinded phase, we see VNS at about 30%, RNS at about 38%, and DBS at roughly 41%. And then over longer term, we have VNS improves to just over 50%, and then RNS and DBS are both probably about 70%, and more similar than different. In terms of other benefits that we see, as I mentioned, the VNS has this antidepressant effect. There's also a magnet that's easy to activate, and individuals can turn on their VNS stimulator if they feel an aura or a seizure imminent. RNS, we get this accurate seizure logging function. It also can be activated with a magnet. And it can be helpful in seizure localization. I mentioned the SUDEP. I don't need to say it again, but I just want to remind you of that. And if we look at a comparison of side effects, VNS, we can get voice change, neck pain or discomfort, cough, sleep apnea can be made worse. RNS, implant site infections are a concern, site pain. Sometimes we see more seizures. That's rare, but it can be addressed by reducing stimulation intensity. And we have to know where the seizure focus is. There's a risk of putting the RNS in the wrong spot if we don't have a good idea of where that focus is. DBS, again, infection's a risk. There can be some tingling at the stimulator. There's transient depression and memory problems. And rarely there can be worsening seizures that can be addressed by adjusting the stimulation parameters. So if you choose one of these treatment modalities, what can you expect when you go see the doctor? Well, your visit's going to have a device programming component. Your doctor is going to give you a wand to hold over the device, either in the chest or in the area of the skull where it's implanted. The doctor will use a pad or a computer to interrogate the device and then adjust the parameters. Stimulation intensity can be made to go more frequently or with more intensity, or if it's an RNS device, can adjust the seizure detection parameters. The part that's also important to consider is for those families that have RNS, that in this case, in this example, I said the patient is working with the doctor. But if you're taking this device home, then what we really have may be the husband is working with his wife to upload the data. So this is a part of the RNS that's different from the VNS and DBS, that there has to be this ongoing effort to upload the data. The more data the doctor has to work with, the better the result that he or she can deliver for that individual. So I hope that you have some idea now of what neurostimulation is all about, what it is, and when to consider it. I think we spent some time talking about the different kinds of neurostimulation and some of the factors that go into choosing and comparing different types of neurostimulation. And then lastly, what to expect will happen during a doctor visit or even when you go home if you have a neurostimulation device. Thank you for your attention. I hope this has been helpful and that you try out some of the other talks that are listed on this website.